The presence of mediastinal lymph nodes and two lymph nodes in non-small cell lung cancer. For reference to the stations of lymph nodes and the importance of invasive mediastinal staging, please refer to one of my earlier videos. So, from the time that Mountain and Dressler modified the American Thoracic Society lymph nodal map for lung cancer in 1987, for almost 4 decades, the stations have not changed. What we describe as N1 or N2 or N3 has not changed. In 1987, in the AJCC 4th edition, every single update since then, N2 lymph node is stage 3. N2 stage 3, N2 stage 3, N2 stage 3, N2 stage 3. But for the first time in 2025 in the AJCC 9th edition, a group of N2 lymph nodes have entered stage 2. When this has not changed for 4 decades, why did the stage grouping change? So the IASLC, the expert body responsible for lung cancer staging updates, so they had 3 phases. In their phase 3, their role was to evaluate the patients that were treated between 2011 to 2020. So basically, lung cancers were getting treated all around the world. Treatment will not stop for research. So obviously, treatment is going on all around the world. Their data on their staging and their treatment that was given, all of them are prospectively entered in their respective databases, cancer data, cancer registries. So now such data is retrospectively analyzed. So now patients treated between 2011 and 2020 were retrospectively analyzed in the phase 3 IASLC. About 50,000 patients for whom the N status data was available were analyzed, and they found out that the prognostic significance of pathologically involved mediastinal lymph nodes holds the exact same value it held in 1980s also. Patients with PN2 did definitely worse than patients with only hilar non-mediastinal lymph nodes who did worse compared to patients without any mediastinal lymph nodes. The separation of curves is very beautiful and very obvious. But one interesting thing to notice is that in the 1980s, for a patient with a pathologically involved mediastinal lymph node, the expected 5-year survival was 25% roughly. Whereas for a patient treated between 2011 to 2020, for a similar stage, for a pathologically involved mediastinal lymph node, the 5-year survival is roughly 47%. So this is quite easily explainable by advancements in the systemic therapy. Cancer care has improved so much. We don't use the same systemic therapy that we used in 1980s. So for obvious reasons, this survival improvement has happened. Now, is there any role in evaluating granularity of this lymph nodal burden? So this was the first question. So this was the first proposition made by this expert group. So what they did was they have data. They have data for about 50,000 patients. So they would do a lot of permutations and combinations and analyzed the data as per small granularity of lymph nodal burden. Single hilar, multiple hilar, skip metastasis to mediastinum without hilar. So, but this did not, initial attempt at granularity did not make any sense. The curves were all overlapping. They did not result in a clearly meaningful prognostic groups and just increased the complexity of the staging. So, after a lot of permutations and combinations, they ended up with this when they realized that they just separated patients with pathologically involved mediastinal lymph nodes, PN2, into two groups: involvement of a single station N2 versus involvement of multi-station N2. That is, for a right lung cancer, involvement of only 4R, invasive mediastinal staging has been done, and station 2R is negative, 7 is negative, 2L, 4L is negative. Only 4R is positive. So this is single station N2 versus for a same right-sided lung cancer, invasive mediastinal staging is said 2R, 4R and 7 are positive. That is multi-station N2. So when these two groups were separately analyzed, they could find a remarkable separation of curves, meaning that patients with single station N2 do significantly better than patients with multi-station N2. So these two have to be placed in the different prognostic groups. So this is the reason for the change 1 when in the AJCC N2 was divided into N2A and N2B. So now we'll see the change for reason for the change 2. How did they become stage 2 from stage 3? So this is easily explainable from these survival curves. So we understand that these stage groupings are a combination of T and N staging. So that is based on their survival. So it is very simple logic. The same has happened. So they have initially this IASLC has recognized that N2A and N2B have to be put separately. They have to be viewed separately because they are prognostically different. So now T1 with N2A, N2B, T2 with N2A, N2B. So this prognostic, this permutation and combination and their analysis of survival outcomes showed a remarkable finding that a patient with a T1 tumor with a single station mediastinal lymph node could offer could achieve a very similar 5-year survival of 50%, similar to a patient with a T2 tumor, that is a tumor between 3 to 5 centimeters, without mediastinal lymph nodes. So a T2 tumor with only hilar lymph node involvement without mediastinal lymph node involvement achieved a 5-year survival of 53%, and a T1 tumor even with involvement of mediastinal lymph nodes single station could achieve a very similar 5-year survival of 50%. So this, if you can understand, so in here, the for example, the blues are all together 46, 47, 42, 43. So that is a stage 3A, a T4 tumor with N0 and a T1 tumor with N2B are both stage 3A, a T4 with N0 and a T1 with N2B, both 3A, because they have the same survival, right? The yellows have the same survival. Just like that, this is the reason for the change 2, where a T1 N2A and T2 N1, when they had the same survival, they were grouped together as stage T2B. Hence, for the first time ever since the time man started treating lung cancers, a specific subset of patients with mediastinal lymph nodes, single station mediastinal lymph node involvement in a tumor that is less than 3 centimeter were grouped as stage 2. This is the remarkable advance in the field of lung cancer treatment, and that is attributed to solely, not to just to a very large extent, attributed solely to extremely significant improvements in systemic therapy, both in the form of targeted therapy and immunotherapy. So now, what is the current role of surgery in patients with N2 non-small cell lung cancer? What is the evidence for that, and what do the guidelines say? These things will be discussed in the next video.